This presentation aims to inform you about the use of the PHQ-9 questionnaire for monitoring patients with depression in the intervention arm of the PROMDEP Randomised Controlled Trial. This is an independent research study funded by the National Institute for Health Research. One randomised controlled trial of using the PHQ-9 in US family practices found that outcomes for patients were improved, even though treatment didn't change much. This may have been because patients felt more knowledgeable about their condition and were more able to contribute to their own assessments, which can be therapeutic in itself. We carried out a feasibility study of using the PHQ-9 plus 2 other patient-reported outcome measures, and also found patient outcomes were improved, but interestingly we found patient satisfaction was reduced among patients using them, possibly because they perceived their GPs weren't interested in their progress because they didn't take the time to discuss the questionnaires with them. In a trial in Sweden, patients monitored with the Montgomery-Åsberg rating scale were more likely to adhere to their antidepressant treatment, although outcomes were not improved in that study. Finally, a recent trial of symptom questionnaire monitoring in the UK improving access to psychological therapies, or IAPT services, found it helped therapists to target treatment to patients who were not improving early on, improving the efficiency of the service. The PHQ-9 has a number of limitations, however. Although previous research has shown it is valid against longer interview-based assessments of depression, this applies only at the group or mean level. Individual patients' scores vary widely around the mean, and there are always false positives and false negatives. Secondly, recent research has shown a mismatch occurs quite commonly between patients' PHQ-9 scores and their own global rating of how they feel. Thirdly, the threshold score of 10 or more out of 27 for considering drug or psychological treatment may be too low, as the PHQ-9 labels more people as depressed at that threshold than the Hospital Anxiety and Depression Scale or HADS questionnaire. Lastly, a symptom frequency score in itself cannot suffice to indicate treatment is needed. The effects of patients' symptoms on their daily functioning at home, at work, and in their relationships are key. So why should you consider using the PHQ-9 questionnaire with your patients? Firstly, it covers the 9 symptoms of major depression systematically. There's no need to go through them all verbally, so it can free up time if completed by patients before they arrive. It shows which symptoms are most frequent, and question 9 asks directly for suicidal thoughts. Most importantly, many patients like using the PHQ-9. It helps them to understand how the various symptoms of depression are part of a recognized single syndrome, which can reassure them that they don't have other things wrong with them. They like to know their scores, and as a result feel more able to contribute towards their own assessments and more involved in their own care. Adherence to treatment can be improved, so patients can benefit even if their practitioners don't change treatments in response to the scores. Crucially, we need this trial to tell us whether these effects can benefit patients significantly. Patients will complete the PHQ-9 at their baseline research assessment, ideally within 2 weeks of them presenting to your practice with a new episode of depression. Patients will get written feedback on their scores, including a traffic light indication of the severity of their depression. A score of 0 to 4 will be described to the patient as no depression and represented by a green traffic light. A score of 5 to 9 will be described as mild depression and given a yellow traffic light. A score of 10 to 14 will be described as moderate depression with an orange traffic light, and scores of 15 or more as severe depression with a red traffic light. A 100 mannequin representation of the proportion of people in the population with the different levels of depression will be used to show the patient how their level compares to the population as a whole. Finally, a brief indication will be provided of possible evidence-based treatments relevant to the severity of depression for the patient to discuss with you. Here is an example of written feedback given to a patient whose score on the PHQ-9 at baseline is 13, indicating possible moderate depression. The 100 mannequin colour-coded chart shows the person that they are among the 8 people in every 100 in the general population who score in the range for moderate depression on the questionnaire. The traffic light indicates they need to think about possible treatment, and the written texts gives them examples to discuss with their GP or nurse practitioner, i.e. referral for psychological therapy or antidepressant treatment. A score of 0 to 4, described as no depression, may be a false negative, which we'll cover on the next slide, so the patient will still be advised to see you again at a follow-up consultation to check whether you still think they're depressed. A score of 5 to 9, or mild depression, indicates active monitoring rather than immediate treatment. If mild depression persists at 4 weeks or 8 weeks follow-up, you should consider the NICE recommended options of referral for group physical exercise, or to your local Improving Access to Psychological Therapies or IAPT service for guided self-help or computerized cognitive behavior therapy or CBT. If the score is 10 to 14 and further questioning at the first follow-up confirms moderate depression, see next slide, referral to IAPT is recommended for possible CBT and further follow-up after another 4 weeks. Antidepressant treatment could be indicated either at the first follow-up consultation if the patient has needed antidepressants before, or if the problem is not settling 4 weeks later. A score of 15 plus, described as severe depression, indicates both referral to IAPT for psychological therapy and antidepressants are recommended, if both are acceptable to the patient. It's important to emphasize the patients will be advised these are suggested treatment options only for discussion with you. We want you, please, to read the PHQ-9, which the patient will bring with them to their first follow-up consultation, around 2 weeks after the researcher has carried out the baseline assessment, i.e. 4 weeks or so after they first presented to you. We also want you to read the written feedback the patient received, suggesting possible treatments. We would like you to take the PHQ-9 score and written feedback into account when deciding on initial treatment for the patient, or a possible change in treatment if you had already started treatment when the patient first presented. At that first follow-up consultation, we also want you to give the patient a second PHQ-9 to take away with them, to complete before a second follow-up consultation with you, again around 4 weeks later. At the second follow-up consultation, now around 8 weeks after presentation, we want you to go over the result of the second PHQ-9 with the patient and again take this into account when deciding about continuing or changing treatment. You can then provide further follow-up consultations as needed according to your own clinical judgment. At your first follow-up appointment with the patient, 2 weeks or so after their baseline assessment by the researcher and 4 weeks or so after they first presented to you, start with a global inquiry before looking at the scores for symptoms on the PHQ-9 questionnaire. We suggest something like, how are you feeling compared to 4 weeks ago? Are you still depressed? Do you think it's worse or better? If the answer to the global inquiry doesn't fit with the score, check why that is. For an apparent false negative, i.e. the PHQ-9 score is less than 10 but the patient says they're still depressed, explore whether the patient has problems which are not measured by the PHQ-9. For example, adverse life events, difficulties in relationships, sexual problems, etc. For an apparent false positive, i.e. the PHQ-9 score is greater than or equal to 10 but the patient feels better or much better, check whether 1 or 2 symptoms are having a disproportionate impact on the score, such as sleep disturbance for example, and whether scores have improved for the first 2 core symptoms. ask, are the symptoms, though coming frequently, not actually all that troubling? Do they not affect daily activities much? If the answer to the global inquiry fits with the score and it is 10 or more, offer active treatment, which could include referral to psychology, antidepressant treatment, or both if the symptoms are severe and having a major impact on daily functioning. Exploring the scores on individual items of the PHQ-9 might indicate that there are particular problems. For example, poor sleep, poor appetite and weight loss might indicate that mirtazapine might be a reasonable initial treatment choice rather than an SSRI. At your second follow-up appointment with the patient, another 4 weeks later, or 8 weeks or so after they first presented to you, again start with a global inquiry before looking at the scores for symptoms on the PHQ-9 questionnaire. We suggest something like, how are you feeling compared to 4 weeks ago? Are you still feeling depressed? Do you think it's getting worse, or is it getting better? If the answer to the global inquiry doesn't fit with the score, check why that is. See previous slide. If the score seems valid and indicates an adequate improvement, i.e. a drop of 5 or more points on the PHQ-9, then we suggest you continue current treatment and see the patient again in another 4 weeks. If the change in score seems valid but is borderline, i.e. a drop of 2 to 4 points only, we suggest you continue with the current treatment, but review the need for a change in 2 weeks rather than leaving it 4 weeks. If there is an inadequate change in PHQ-9 score, i.e. a drop of 1 point or no change or an increase in score, this indicates you should think about changing treatment at this point, for example adding in an antidepressant or changing the antidepressant if the patient is already taking one, and or referring for psychological therapy. Finally, we want to emphasize that the patient's clinical care remains your responsibility and not that of the research team. Therefore, any suggestions for treatments generated for patients as part of the feedback given to them on their PHQ-9 results are just that, suggestions, which can be accepted by the patient or by you or not. The patients will be informed that their feedback is just a brief and simple indication of the types of treatments which may be offered to people with the particular level of symptoms they have reported on their questionnaire. We will explore, through semi-structured interviews with a sample of participating patients and practitioners, the effects of providing patients with brief advice on possible treatments, on their consultations, and on the patient-practitioner relationship. If you have any questions in relation to this guidance, please do not hesitate to contact us on promdep@soton.ac.uk or telephone 02380 591755 or 02380 591 863. Thank you.